Okay, let's get started. So welcome everyone to the SADS Foundation's Living with SADS webinar entitled Exercising with a SADS Condition. On behalf of the SADS staff team and our presenters, thank you for joining us tonight. I'm Marcia Baker, the Program Director with the SADS Foundation. We have two presenters tonight who are volunteering their time and expertise. So it's my pleasure to introduce them now. First, we'll hear from Dr. Rachel Lampert, a Yale University professor of medicine and cardiology with research interests in arrhythmias, ICDs, and exercise and sports medicine. She was the lead principal investigator of the multi-center LIVE LongQT study, in which the SADS Foundation was also a collaborator. In her talk today, she'll share some of those published results. In addition to LongQT, Rachel will discuss exercising with CPVT and Brugada. Following Rachel's presentation, we'll hear from Brittney Murray, a cardiac genetic counselor with Johns Hopkins ARVC program in Baltimore. Brittney has been with Johns Hopkins program for over 20 years and very experienced in the clinical management of individuals and families with ARVC or ACM, arrhythmogenic cardiomyopathy. Johns Hopkins is also the hub of a large international research program where Brittney and her colleagues, Dr. Hugh Calkins and others, collaborate with world experts on all aspects of ARVC. She will be talking today about exercising with arrhythmogenic cardiomyopathy. Following these two presentations, you'll have a chance to ask your questions. Please type the question into the chat field and we'll address them at the end. As always, please keep your audio microphones muted during the presentations. The webinar is being recorded and the link to the recording will be emailed to all of you in a few days. So now it's my pleasure to turn the program over to Dr. Rachel Lampert to get us started.
Thank you, Marcia. Are you seeing the screen as a single slide?
Yes, it's good.
Okay, great. Thank you. So as Marcia said, I'm so pleased to be here speaking to the SADS group today about exercise and sports, and I'll be focusing on electrical disease, LongQT, CPVT, and Brugada, and then Brittney will be talking about arrhythmogenic cardiomyopathy. Oh, you know what? Let's see, we didn't do this part.
Arrow key.
The arrow key is not
there.
Okay, wait, now it's working. All right. So we're all here because there are a lot of questions around exercising with channelopathies. How much exercise can I do? How hard? What type? How do I get started exercising more? Competitive? Can I compete? What about recreational sports? So I'd like to start with some ancient history because it really is important to understand why we're asking the questions that we ask today. So for a very long time, competitive sports for the patient with long QT was basically felt to be restricted. So guidelines had come out since 1985, and every year, or every time they came out, every 10 years, the recommendations were the same. Asymptomatic patients with baseline QT prolongation should be restricted to Class 1A sports. Now, what are 1A sports? When we think about sports, we classify them based on their dynamic component and their static component, basically aerobic, anaerobic, cardio, weights. And so 1A are the least intense for all of those: billiards, bowling, cricket, curling, golf, riflery. Some of these activities probably didn't even know were sports. And while our elected officials like to do all of these things, our patients and you all often like to do things that are more active. So what was the rationale for this restriction for so many years? Well, it started really back in about 25 years ago when some data came out that patients who had particularly long QT1 had sometimes presented in the setting of exercise. And this really was the basis for these restrictions. But it was an important caveat to this data was that these patients weren't diagnosed yet with long QT. This was often the event that led to their diagnosis. And so they hadn't been treated, they hadn't been risk assessed, they weren't on any beta blockers. But for the people writing the guidelines, basically, in the absence of data, their feeling was go with conservative. So we didn't know how treated patients, or those guideline writers didn't know how treated patients were actually going to do. But as the guideline writer said, generally conservative. It's a prudent posture to assume when the amount of available data and evidence is limited. And that's really the history of why of this restriction. So as we're thinking about restriction, though, there are downsides. There's really so many benefits to participation in sports. Basically, we know that children who are active, they do better in school, they have less risky behaviors, they go on to have more active children, and the cycle continues. And we know that sports build so many of the qualities that we want our children to have. This was a study that was not particularly about long QT, but it was a qualitative study for kids who had defibrillators, adolescents who had defibrillators for all different reasons. And they weren't specifically focused on sports, but they basically were asking these adolescents, these teenagers, about their experiences with their defibrillator. And one of the most dramatic findings that these kids were reporting was that it was really the inability to do sports that was affecting me. So here's Matilda. Every kid runs around. I was crying. I hated the doctor. It affected me because I was like not normal. Kids could do stuff and I couldn't. Here's her mom. You see her crying and saying my life is over because this is one thing I like has been taken away from me. So restriction really impacts kids and older people as well. So since 2005 through 2015, really in the past 10 years, there have been some really big changes in how we think about exercise and long QT. And those changes are really based on three aspects. So first of all, there's actually now some data. Now, I put these pictures of big data. I wouldn't say it's really big data compared to some big data, but it's a lot more data than we had before. There's also changes in thinking about how decisions get made. It used to be that basically doctors just, told patients what to do, whereas now there's really a focus on what we call shared decision making that I'll talk about towards the end. And finally, because of these two trends, there have been some major changes in guidelines as well. So what data do we have for the athlete who's actually been diagnosed with long QT as we're thinking about weighing safety and quality of life? So the first data that came out about this came out from Dr. Ackerman's practice there at the Mayo Clinic. So they looked at the records of all the patients who had been seen at Mayo for the past 10 years. And the approach at Mayo was to give the athlete and their family enough information about the prognosis and the guidelines to make an informed decision. So what these patients that they reported, there were 353 patients with long QT types 1, 2, and 3, and there were 130 of them who had chosen to continue sports, of whom some of them were concealed. They had the gene, but a normal EKG, but about half of them did have long QT on their EKG as well. They were all treated appropriately. They were there at the Mayo Clinic getting the care they needed with beta blockers. Some of them had had surgery for cardiac sympathetic denervation. Some had needed ICDs and had ICDs. Now, of all of these athletes who had gone back to play, there was only one who had an arrhythmia during sports. And it was a child who was known to be high risk. He had an ICD and he'd had a cardiac arrest and he wasn't taking his beta blockers. And so it's something that it wasn't surprising. And it was also in a patient who was protected by their defibrillator. So following that series from the Mayo Clinic, several other groups looked at their experiences and published similar series. So Children's Hospital of Philadelphia, 103 long QT patients doing sports, again doing well. Boston Children's, the total of 1,200 years of follow-up. They did have some events, but they were all, again, individuals who were known to be at risk. Most of them had ICDs, and none of the events actually happened when they were doing sports. So the next piece of data came from our ICD registry. So this was a prospective study that wasn't only for long QT, it was for any individual who had a defibrillator who had chosen to go back and was participating in sports. Now, during the time of this study, similar to long QT, the actual guidelines said that individuals with ICD should not be doing sports, but these were individuals who had chosen themselves with their doctors, or some maybe without, to go ahead and participate in sports. So, and what we then did, we identified them. We enrolled them if they were doing it anyway. We didn't encourage people to do things they weren't otherwise doing. And then we followed them prospectively for 4 years. And of that group of 440 athletes with defibrillators, the largest group had long QT. And of those individual defibrillators, 2 of the 87 had an appropriate shock for ventricular arrhythmia during sports, actually the lowest of any of the groups. There were no activity-related shock failures, no one requiring multiple shocks, no one that the shock didn't work. And so while a few people, excuse me, had gotten shocks, basically no one had any significant problems. And so that was, again, it was just a subset of patients with long QT. So based on that preliminary data, the retrospective series from the different sites and our subgroup analysis from the ICD registry, we then embarked on a prospective study of individuals with long QT called Exercise and Genetic Cardiovascular Disease, or Live Long QT, and we did have an HCM arm as well. So many people on this call may have participated in that study. I know quite a few people did enroll through SADS to be part of this study. So the aims of Live Long QT were to compare the moderate and we ended up comparing the vigorous exercisers compared to those exercising moderately or who were not exercising, to look at the incidence of arrhythmic events over 3 years. And then the second aim was to look at the quality of life in the exercisers and the non-exercisers. So this study enrolled individuals who had, for the long QT arm, long QT, or if they had the gene for it, even if they didn't, their EKG didn't show it, age 8 to 60. Some had a defibrillator, some did not. What the participants did, they were followed for 3 years with a brief internet questionnaire every 6 months. And then we obtained records to see how everyone was doing. So at the beginning, they had filled out questionnaires talking about how much exercise they were doing. And we then classified them into the vigorous exercisers, the moderate, and the sedentary individuals. So this study came out in just this past August of 24, in the journal Circulation, one of the cardiology journals. And we enrolled a total of 1,400 people enrolled in this study, 1,413, of whom about half of them were exercising vigorously, and the other half were either moderate exercisers or less vigorous. And among the vigorous, about half of those were competitive, and half of them were not competing. So we had about a third of them, of the total, I'm sorry, about 13% of them were children, 35% were young adults, and then about half of them were over 25 up to age 60. Overall, we about 2/3 were female, 1/3 were male, which is about what we would see in any long QT population, more women than men, or girls than boys. About 44% of them had long QT1, and the others had a mixture of long QT2 and 3 and other channels and types. So we found that and the events that we were following them for were these: either a sudden cardiac death, a resuscitated cardiac arrest, an arrhythmic syncope in patients who had an ICD, and then patients who had passed out or had syncope but didn't have an ICD, and then finally those who had ICD shocks but hadn't actually passed out. And what we found was that of the total individuals who had one of these endpoints was 2.6%. And it was pretty much identical between the vigorous exercisers and the non-vigorous. 2.6% of the vigorous, 2.7% of the non-vigorous had one of these arrhythmic outcomes. And when you this is a curve where we look at the percent having the event. This is the follow-up time here. And you can see that the number of people who had events, the blue people are the non-vigorous, the red are the vigorous. They're exactly the same line, showing us that the event rate was the same. And then we look at what's called a hazard ratio. We say, well, we adjust for different factors that might be different between them. And again, the hazard ratio is just about 1, meaning that the two groups are equal. We looked at some subgroups, the long QT1 subgroup, the long QT2, those who were symptomatic, those who were not, those who had prolonged QT on their EKG, those who did not. And for all of those groups, the results were the same. Basically, the people who were exercising vigorously were not having more events than the people who were less vigorous or even competitive. And we then looked at really the most active group, 14 to 22, which we sort of chose to choose sort of high school, college. And we compared those who were competing interscholastically, the varsity type athletes, with everyone else in that age group. And again, did not find an increase of events in the athletes. So that was a really a wonderful finding, and I think is important for everyone to know. And I'd like to thank you to everyone who participated. So, we do have a long-term follow-up. Some people may be involved in that. And some people, if anyone on the call was participating in that study, thanks so much for participating. So there was, as a result of that, first as a result of some of the prior data, the guidelines started to change in 2015. And that what they described was that sports may be considered for the athlete with previously symptomatic long QT, assuming they were adequately treated, they were on beta blockers, sympathetic denervation, ICD. The point wasn't that everyone needed all of these. The point, though, was that that everyone who wants to participate in sports should make sure they're being seen by an expert in long QT who can really make sure they're appropriately treated as they need to be. Appropriate precautions, everybody knows, avoiding drugs, staying hydrated, avoid hyperthermia from fever, as everyone knows, are the precautions in long QT. Other things that were suggested for some people may want to think about having a personal AED if they don't have a defibrillator. Not everyone needs to do this, and it's something to talk about with your doctor. And finally, establishing an emergency action plan with the school or team so that really everyone, if a young person's going to go back and be on their high school or college team, that really everyone knows what's going on, everyone's on the same page, and everyone's working together as a team. So the most recent guidelines came out just recently from the Heart Rhythm Society. And we actually went even a little bit further to say not only is this something that may be considered, but it's actually reasonable in a shared decision model, again, after appropriate risk assessment, working with the doctor, education, initiation of appropriate therapies. And then we talk about some of these general concepts for people with long QT who do want to be very active. And we really focused in this document on moving from if people with long QT should be exercising vigorously to how. How can we help make that as safe as possible? So this is, these types of algorithmic diagrams are always a little bit overwhelming to look at. But if you look at long QT, we see avoiding triggers, we see treatment, beta blockers or mexiletine, dose titration on an exercise stress test. So giving yourself and the doctor a chance to see how do things look when you actually are exercising, and then go back to play. If you do have an event, think about a cardiac denervation, etc. Sometimes also too, people sometimes who want to be very vigorous, if beta blockers aren't agreeing with them, sometimes might go to the sympathetic denervation. So again, it's really about thinking about how can we help facilitate you getting back to the things you want to do. So what about CPVT? CPVT is a different sort of an electrical disease than long QT or some of the others. In CPVT, adrenaline is really what causes the arrhythmia. And in fact, ICDs don't always work in the setting of adrenaline because shocks cause more adrenaline, causes more arrhythmia, causes more shocks. So CPVT is a little bit different than long QT. In the ICD sports registry, we did have individuals with CPVT who had gotten defibrillators and had gone back to play. One of these people did have multiple shocks after physical activity. And there were a couple people with idiopathic VF, which at the time may have been that they did have CPVT, that also had multiple shocks. So I think we have to be a little bit more careful with CPVT. Now, there is one series, again from Mayo Clinic, of 21 athletes with CPVT who decided to continue to compete. And they were doing about the same as the non-athletes as far as recurrent arrhythmias. Again, these are people who have been cared for really by the top leading experts to make sure that they're adequately treated as they're making this decision. And here, this is an editorial from some other CPVT experts, sort of being cautiously optimistic, I would say. So CPVT, again, if you look at this algorithm, it's a little bit different. Return to play for CPVT, it's an orange. It's not a green or even a yellow the way long QT is, which means we take a bit more caution. And if individuals with CPVT are going back to sports, but they're having events, then it really is something that is the one time where we maybe think about taking up a less active lifestyle. But that's not common. Now, what about Brugada? With Brugada syndrome, there's really no evidence that playing sports, there was no suggestion that playing sports might increase events in Brugada. Most events in Brugada occur at rest and during sleep. So we really focused for Brugada on avoiding the standard triggers, such as the drugs that exacerbate Brugada, alcohol, heavy meals. Actually, cannabis now is being shown to exacerbate Brugada, but fever, as we know. And so really the emphasis for the athlete with Brugada is on staying hydrated, avoiding hyperthermia, avoiding the standard triggers. So we have a lot of data at this point on all of these, but we can never have too much. And so we now have another registry ongoing. This is through the University of Washington, and SADS has been working with this group as well. And I'm on the steering committee. I'm not the primary investigator. This is an outcomes registry for cardiac conditions in athletes for athletes who have gone back to play, and again is following them prospectively so we can get even more data. I just want to take 1 second to talk about decision making, because one of the things that we've really focused on is this concept that's called shared decision making, which is really prioritizing preferences, values, goals of the patients and of the athlete. And again, I think as a patient, if someone told me like, well, patient-centered care is kind of a new thing, I'd be saying, well, what were you doing before? But it's really, the focus really has changed to the doctor as working with the patient to come to a decision, as opposed to the doctor just telling the patient what to do. And so it's really important to be working with the doctor who really thinks about how to talk about this kind of thing. We did a study of athletes who had gone back to play. A lot of them were from Mayo or from the ICD Sports Registry, and they had had a very difficult time. This was before the guidelines changed and the concepts of shared decision making, and they really had to change schools and meet with many people, and they really had become very cynical. And so many of them said, that doctor didn't care about me. He just, was covering his what. And it was it was a lot of cynicism, I think, and I'm hopeful that as the medical community is moving more towards shared decision making, that we will see some of that get better. So how do we talk to the family and the athlete about returning to play? Talk about the data, how the person in front of me is similar to the people in the studies, or if they weren't similar, why, what might be different. And I also talk a lot about the spectrum of comfort with risk. Different families feel differently about sort of how to approach risk with their kids. A girl at the top sailed around the world by herself. Obviously, that at 16, that family had a lot of tolerance for risk. Other families these days are have their kids not playing football anymore because of the risk. And it's something to kind of really just think about with your family, how you think about your life in general. So most importantly is working closely with your doctors as you're going back to play. And then once you have gone back to play, to make sure that the treatments are still the appropriate ones and make sure things are going okay. So I'll stop here and turn things over to Brittney.
Thanks, Dr. Lampert. Yes, everyone, Marcia has told me that we are going to speed through all the content, and then we'll have hopefully lots of times for questions at the end. So I'll get started and go through that. Let me share my slides as well. Okay, and you're seeing
Yes, all good.
I was just texting with Marcia. I've had Zoom problems in 2025. So if I freeze and disappear, Marcia will show my slides and I'll join from my phone. Anyway, so I have a harder job of painting, maybe not so nice of a picture as the data shows in channelopathies as in arrhythmogenic cardiomyopathy. It's also a little bit harder because arrhythmogenic cardiomyopathy is a really broad field. Arrhythmogenic cardiomyopathy, just that word, covers a lot of things. ARVC is a small subtype of arrhythmogenic cardiomyopathy. So we'll talk about the data in the specific types of arrhythmogenic cardiomyopathy and what we're learning, because it is continuing to evolve. And we're learning more and more and more as we get more data. And we will continue to share that data with you all as we get it. Okay. There we go. So some of this, I'm actually really happy. Dr. Lampert already went over a lot of some of the shared concepts between these two. Like we, your medical team, we know that exercise is important. We want you to exercise as much as possible. We know that it is emotionally, physically, socially important. And so we want to factor this back into your life. Your physicians who work in these fields, we don't like being restrictive. So why we study this data so much and why we put out so much information and all of that is because we want to help you engage in these things safely, but to make sure that you know what the data shows and how exercise may impact your disease. So in arrhythmogenic cardiomyopathy, where the data started that was back in the early 2000s, there was a bunch of Italian papers which really linked sports participation in ARVC specifically, or as it was called then, ARVD, to a 5 times higher death rate. So they were just noticing predominantly that exercise had a lot to do with the death rate in ARVD patients, and that ARVC patients were a biased, huge population were athletic. And then there was this big landmark study in 2006, the Kirchhoff paper, that really launched a whole bunch of research that showed in mice translational evidence that the endurance training in mice that had ARVC mutations accelerated the RV dysfunction and arrhythmias in these mice. So it wasn't just that exercise provoked arrhythmias, it was that the exercise was actually progressing the disease. So therefore, a lot of physicians started trying to restrict or understand exercise in ARVC patients. I know we did at the Hopkins clinic as well, but then we really wanted to have data to back this up because, as we say all the time, mice are not humans. And so we looked at our patients, and Cindy James and our whole team, we ran this retrospective interview-based study calling patients. I did a lot of this. My colleague Crystal did a lot of this, where we actually were interviewing a lot of you on the lifetime exercise history and calculating these met hours of exercise that our patients did prior to presentation and even if they did after presentation. And unfortunately, it didn't show a very good picture, and that we found that Dr. Lampert showed graphs like this that are called Kaplan-Meier curves. And here is the green is the athletes, and then the blue is the non-athletes. And you found that the athletes had much earlier and much more VT, and much earlier and much more Class C heart failure than the non-athletes. So this was really some of the first evidence in patients that directly showed that, yes, the exercise was bringing on the disease presentation at earlier ages. And down here in figure 2, this other graph, the more in quartiles, the more exercise you did, the more likely you were to get ARVC and at an earlier age. And ARVC patients were disproportionately athletes. So this study really drove a lot of the recommendations in the field that endurance training specifically, but a lot of intense exercise was actually progressing arrhythmogenic cardiomyopathy, or in this case, this study specifically, it was ARVC patients, and making it worse. So again, getting back to, there's 2 ways I talk to all my patients in clinic every day. This is what I do all day, is talk about exercise in clinic with ARVC patients all day, every day. And I always tell them there's 2 ways exercise influences ARVC. So yes, catecholamines provoke arrhythmias, so this is some of the things they were worried about in the channelopathies, and probably why patients who are compliant with their beta blocker, will have good control, because you block that adrenaline that's triggering arrhythmias. However, in ARVC, we're also worried about the progression of the disease, of the myocyte death, ripping apart those heart cells and making new scar that's progressing disease, to driving progression. More scar equals more VT equals more heart failure. And then that original study that our team did at Hopkins was not a fluke, and has now been validated in many, many different populations across the world, other ARVC patients in different countries, different mutations, different study groups. So it has really shown up to hold up that, yes, this data is rock solid that vigorous exercise impairs the myocardial function and progresses ARVC. So the data is not questionable about in ARVC patients specifically. And Dr. Lampert put this up earlier as well, that this has led to some of the guidelines that yes, ARVC patients should only, because of all of this data, should really only stick to this 1A sports, cricket, bowling, golf, riflery. They put yoga in this version. They were, hip in the 2000s now. But again, these are not really sports that our patients want to do. So we, sometimes they do want to do them, but they want to do them in addition to other things. So we have spent a lot of our program's research time really trying to find where the limit is. And this is something that I'll talk about throughout the talk. The exercise is not all created equal. And we've really tried to understand what the safe limit is, what can help us achieve that balance of your high quality of life and all those benefits of exercise that I showed in the beginning, while keeping you safe from progression of your disease additionally. So now what? So I put this pendulum in here because there seemed to be this big swing. So for the early 2000s, we spent so long as a program trying to convince doctors, our colleagues around the country, around the world, hey, exercise is a big deal in ARVC. You really need to be able to stop progression in your patients by limiting their exercise. You really need to talk to your patients about exercise. And then it seemed that the pendulum swinged and everyone finally got it, that, hey, this is important. But then it was too restrictive. Is that the physicians were so afraid, so not into the nuances of the data, that they were shutting down everything. That no, your heart rate can't get over 90, or no, you can't do this, no, you can't do that, and being extremely restrictive. And that's really what we wanted to avoid of, hey, there needs to be some more data in the middle of what level of exercise is okay, where we need to meet in the middle, because we can't have these vast pendulum swings, and being absolute is not helping anyone. So some of the data that we've been able to gather now that there's been about 20 years of genetic testing in ARVC. So some of the first clinical genetic testing in ARVC and arrhythmogenic cardiomyopathy came out about 2006. So we're coming up on almost 20 years. So now we're having enough data of patients with all the different genotypes to pool them and notice differences. And we do see some differences. And then so that's why I was careful to talk about those earlier studies and talk about, those are patients with ARVC. So very specific subtypes of arrhythmogenic cardiomyopathy, because not all arrhythmogenic cardiomyopathy is created equal. So we've tried to gather more and more data on all the genetic subtypes to really be able to tell the difference. So in just because of how PKP2 ARVC presents, plakophilin-2 ARVC for a long time in North America was the most common type of classic ARVC. So it presented with this right-sided ARVC, and for a long time, 70% of my patients had PKP2. So they pathogenic variants. So they really dominated a lot of those early studies, right? What we've seen now also with more and more data that desmoglein-2 is more rare than PKP2, but at least in the mice, we do now actually have data that just came out last year that desmoglein patients seem to react to exercise similar to PKP2. So if you're looking on exercise guidance or exercise data specific to your genotype, if you have PKP2 or desmoglein-2, you can probably look at all of those initial studies because they were predominantly made up of your genotypes. So that's going to be specific evidence that you can use to make your decisions on what your exercise level is with your medical team. So we are using this data also not only in people who have ARVC, but also especially in PKP2 and desmoglein patients in family members. So family members who don't have disease yet. And we did this study, and I'm number of years ago that showed actually that we can potentially avoid the disease showing up in family members if we avoid this really intense, vigorous exercise. But where's the level? Where's the safe level? So I have so many patients who will come to me in clinic and they'll say, you know, well, you can't restrict my exercise. You know, you need exercise to be healthy. You know, everyone will say we need, you know, you can't not exercise. You're going to get heart disease. But what the American Heart Association recommends, if you actually go to their website, is not what the majority of our patients are doing. They're talking to the general American public, and they're like, hey, get up off the couch. Don't be a couch potato. The American Heart Association recommends 3 to 4 times a week, about 30 to 40 minutes of light to moderate exercise. And that's what's recommended for heart health. So we looked at this average med hours recommended by the AHA in our family members to see who had kind of kept their exercise below those levels actually showed up with disease, and people who kept their exercise at those levels of the AHA recommended 3 to 4 times a week, 30 to 40 minutes of light to moderate exercise, they seemed to be protected and not really have advanced disease. So, you know, when patients ask me for a safe level, this is kind of where we're starting to get that evidence back towards it that, hey, no, you know, I know that you run a marathon in every state across the country, and you want to be able to run 10 miles of a jog every morning, but that's not the type of exercise that we think is going to be sustainable if you don't want your disease to progress. But it's not couch potato. You can definitely get back in, be an active person. And again, a lot of this data is in PKP2 and desmoglein carriers showing that, hey, yes, you can still be active, you know, symptom limited, of course, but we just don't want you doing the really high level MET hours that most of our patients are used to. And so then going through some other genotypes as well. So in TMIM43 ARVC, which is the Newfoundland founder variant, which is a more rare type, but just showing that the Newfoundland group did also verify that exercise was a big risk factor in that genetic subtype as well. But then also for a different type of arrhythmogenic cardiomyopathy, we worked with our Dutch colleagues to look in that population of patients with phospholamban arrhythmogenic cardiomyopathy, a different genetic subtype. You can see, we talked about these lines, both Dr. Lampert and I, the lines of the difference between events, time to diagnosis, heart failure, arrhythmias, they all seem to be very similar in inactive and active people. So phospholamban, probably somewhat related to where the phospholamban protein is in the heart versus the desmosomal genes, does not really seem to have an impact on exercise. So the phospholamban patients are often treated from an exercise standpoint like other cardiomyopathy patients, not necessarily like ARVC, PKP2 ARVC patients. So desmoplakin. So desmoplakin has been a hot topic for a number of years because desmoplakin arrhythmogenic cardiomyopathy can behave more similar to phospholamban cardiomyopathy, but is very arrhythmic like PKP2 cardiomyopathy. And so there was a big question on how much that early data that we showed that was validated in all those populations would hold up in the desmoplakin type of arrhythmogenic cardiomyopathy. And in this genetic subtype, we found that it presented a little different, but also really did show to have some impact with this high level of endurance training. You'll hear me talk over and over again about endurance training, and I'm sure we'll get into this discussion as well. Desmoplakin patients disproportionately have these myocardial injury episodes of inflammation and chest pain that are pretty unique to desmoplakin, although other ARVC patients, PKP2, have them as well, but they're really common in desmoplakin. Endurance training seemed to increase these inflammatory myocardial injury episodes. And actually, in a bigger study of almost 1,000 desmoplakin patients, we found that these myocardial injury, these inflammatory chest pain, troponin leak episodes were associated with bad outcomes over time, that they led to more arrhythmias, more heart failure. And so even though it affects the presentation of progression a little differently than PKP2, we do still now have data that endurance training in desmoplakin carriers is also damaging over time. And this paper was just published at the end of last year. So this is hot off the presses for you as well. Also, a lot of you, I don't want to forget gene-elusive ARVC, because 1/3 of my patients with ARVC don't have an identified genetic subtype. And so, over and over again in clinic, we talk about how frustrated they are. They don't have a lot of data specific to them. But this is complex because it's a heterogeneous group. Like I said, arrhythmogenic cardiomyopathy is a broad category. However, if the phenotype looks like classic ARVC, the right-sided ARVC, and they meet ARVC task force criteria, we talk a lot about this phenotype of exercise-induced right-sided ARVC. And we see this, that our gene-elusive patients are disproportionately these huge, huge athletes. So if you look the mutation carriers in green and then the gene-elusive in blue, the number of Met hours of lifetime exercise they've done more, ton more than our gene positive patients. And so it's exercise itself that's actually driving the disease showing up, then disease progression. And the data actually shows that disproportionately these patients can really stop and slow down progression if they pull back on the exercise, because exercise is such a driver of their disease. And so there are other types of arrhythmogenic cardiomyopathy that we don't have gene-specific data on yet. So the jury is still out. We're still trying to collect enough data to have power to say anything about Desmond, filament C, and RBM20 arrhythmogenic cardiomyopathy specifically. So if you know your gene, which you should, if you don't, ask your genetic counselor or your doctor to go over it with you again. And if you haven't had genetic testing, heavens, you really should. But you should look at the data that's specific to you, is kind of my take-home point. So I'm really glad, especially because I want to have time for questions and get to those, that Dr. Lampert already talked a lot about shared decision-making and explain what that is. Because that's, I think, really the take-home point that I want to drive through all of this data. All of this data is more and more that we're trying to give you a personalized risk approach that you can factor into your decisions on what you do, what level of exercise is okay for your life, for your happiness, and balance that with the risks. And that we are very, very open to having discussions about this. And we showed this was a genetic counseling student, Jess Sweeney, who worked with my colleagues and I to survey many of our patients. You may have participated, those you were on, and found that those who had less decisional conflict and decisional regret around their decisions around exercise, and their decisions may have even been after shared decision making, they decided to cut back their exercise. But as long as it wasn't something told to them and they participated in that discussion and it was a shared decision-making model, they had much, much less issue with that decision rather than if they felt it was a decision that was made for them. And that's something that we've been really practicing in our clinic for quite a while. And so I think that this is where I want to go. Like I said, I was kind of a Debbie Downer about exercise throughout this discussion on arrhythmogenic cardiomyopathy. But I tell all my patients that exercise modification does not equal exercise restriction. We want to work with you to find ways for you to move your body that bring you joy. And I have lots of people who email me from Timbuktu and are like, hey, I have ARVC. What level of exercise can I do? And that's not something that I can answer over an email or in the Zoom chat. It really depends on your clinical evaluation. It's not the same for any two arrhythmogenic cardiomyopathy patients. It depends on what your arrhythmias look like, what your heart structure looks like, how stable you've been, all of that. And it's this back and forth risk-benefit discussion until we arrive at a happy medium, right? My biggest thing to you, and this is something that my physician colleagues I see doing all the time in arrhythmogenic cardiomyopathy, and it's not only is there no data to support it, but there's new data out of our colleagues in Zurich that it actually might be just flat out wrong and dangerous. There are not a specific heart rate limit that's safe. Like, so if someone says, hey, as long as you keep your heart rate below 120, you're safe. There's no data to support that, especially since most of our ARVC patients are on beta blockers, and beta blockers lower your heart rate. And also our patients are former athletes who have low resting heart rates. And so that is not a valid measurement. Sometimes an individual can work with a heart rate in terms of, we discuss with them that you need to lower your intensity and duration. And if you find an intensity where, yes, you can carry on a conversation, you're not dripping in sweat, where you're moving your body, but you're not being intense, and then you match your personal heart rate to that intensity, you can use heart rate in that setting. But there's not a broad population heart rate that under 120 beats per minute is safe. That's just wrong and dangerous in many cases, because most of our patients are probably exercising more than they think. And on the other hand, you can spike your heart rate up to 150 carrying a flight of laundry up, or carrying a load of laundry up a flight of stairs. So it's really not helpful to have these heart rate parameters. And like I said, endurance training seems to be the most damaging: long distance cycling, swimming, running. Weight training at moderate levels at a slower pace seem to be fine. Pilates and yoga are fine. And even some cardio at a lower intensity, lower duration seems to be in that AHA kind of safe level for ARVC patients. We can have a whole separate talk about asymptomatic pathogenic variant carriers, aka your kids, and whether to restrict them or not. But this is a complex family discussion. We don't restrict recreational sports at all, but these highly intense competitive sports are a family discussion decision with us and your family, and the pro cons of the social value of that sport versus preventing disease and where we go. It's much easier in our vast experience to start this conversation as a young child. The longer patients know about their genetic risk, and the longer they're aware of their kind of sports lifestyle that they should have, the better they do psychologically. All of the data shows that the kids who grow up knowing they carry these variants do really, really well versus those who find out later. So like I said, trying to wrap up so we have time for questions. There's tons of data that extensive endurance training especially progresses ARVC and some forms of arrhythmogenic cardiomyopathy. We're now starting to have beginning data for gene-specific guidance. And a specific exercise prescription broadly at a population level is difficult to give. But it's best to meet with an arrhythmogenic cardiomyopathy expert and review. And this is what we do all the time in clinic. I'm sure Dr. Lampert does, Dr. Calkins and I do, that we can go over with you and find a prescription that works for you. And that is the most important thing that I want to leave you with, that this should be a shared decision-making discussion with your medical team and your gene-positive family members and their medical team. And this is the most effective in the long run, both for you and your family. And then I'll just leave you with a little picture of our ARVC team. There's Dr. Calkins in the middle, and Crystal over here. Many of you recognize my right hand. So happy to take questions with Dr. Lampert.
Thank you very much, Brittney and Rachel. We appreciate your time and overview. We had some questions come in early on that are directed to Rachel, and then we'll address a few more. So the first one was from Chris, and he was asking Rachel, any data for 70-year-olds?
So we don't have specific data on individuals over 70. In general, people with long QT who have reached age 70 are generally lower risk than people who are younger. And so anybody over 70 has a risk spectrum, just as a younger person that you should talk to your own physician about. But I wouldn't expect the data to be different for individuals over 70. Now, people, as we get older, we can be prone to other things like coronary artery disease, and how that might interact with long QT, we don't know. But I think, it's a conversation to have with your physician, assuming you don't have other risk factors, you aren't on other medicines that are prolonging your QT. I wouldn't see the data on older individuals being different than the younger group we studied.
Okay, thank you. Our next question is, Rachel, for you too. What research has been done specifically in long QT type 1 and open water swimming? Surely, if treated and compliant, the rules around not swimming should also be relaxed. Is it very hard to get medical certificates? It's very hard to get medical certificates to swim in open water due to her long QT syndrome.
So open water swimming is a really hard conversation for not just long QT1, where there is some data that untreated people have a higher risk of events with swimming, but really anyone with an arrhythmogenic condition. Live long QT, live HCM. The point of those studies was not to say that no one is ever going to have an arrhythmia during exercise. The point of what those studies really showed is that if you are habitually engaging in exercise, your overall risk is not higher than if you're not. And one of the reasons for that is that if you're exercising, you might have an event during exercise. And if you're not exercising, you're going to have an event running for the bus, doing something else. And so these studies don't mean that there's never going to be an event during exercise. Now, the issue with open water swimming that's totally even different than swimming in a pool is that if you do have an event, it's hard to get you saved. It doesn't mean it's impossible. And there are there are individuals who choose to just take that risk. But we also talk about something called a personalized emergency action plan. So I didn't really talk about this in my talk, but athletes who are going back to play, whether particularly with swimming, but with other types of exercise too, should have an emergency action plan. In general, emergency action planning is something that we do for the population in general, as far as we always have AEDs on soccer fields and in gyms, and people that are identified that are going to, use the AED. The perfect example was the Damar Hamlin cardiac arrest, where everyone was just like, boom, boom, boom. Everyone knew just what to do and brought him back. So for someone who knows that they are starting out with a somewhat higher risk than the general population, you want to not just rely on the general population emergency action plan, but make sure you have one yourself. So for people doing open water swimming, it's a little bit hard in a race, but if you're going to just choose to do open water swimming, have a boat with you. Make sure the person in the boat knows how to use an AED. Make sure they know who's watching out for you, how they're going to pull you out of the water. Not because I think this is likely to happen to you, but because you need to be prepared. And so I wouldn't tell someone with long QT or other arrhythmogenic conditions that you should never do open water swimming, but it is something that you want to think about more than other types of activities for that reason.
Okay, thank you very much, Rachel. Okay, a question probably also for Rachel. If Brugada syndrome VT storm is presented after exercise and not during rest, does this change the flow chart suggestions?
Yeah, that's a really interesting question. That's not that common that I have heard of that happening. I think there's a lot of individualized sort of medical decision making going on with this type of situation. So Brugada patients having storms, maybe getting put on medications, quinidine, other types of medications that can treat Brugada. Sometimes you can even have an ablation with Brugada, depending on the medical situation. So for anyone in general who has a storm with Brugada or anything else, or even just a single ventricular arrhythmia event that occurs with or shortly after exercise, you want to make sure that's treated before you go back. So if you're having a storm with Brugada, then you're thinking about this set of approaches. If you have a shock or a series of shocks or even a single shock with long QT, you're thinking about a different set of therapeutic options. But you want to make sure that you and your doctor are confident that your underlying propensity to have arrhythmias has been addressed and that the arrhythmias have been suppressed. So, I can't, obviously we can't address a specific recommendation to a specific individual situation, but that's sort of the general concept is how to think about for the athlete to think about if you've had arrhythmias in the context of exercise or afterwards.
Okay, thank you, Rachel. Chris also is asking to Brittney the same question about 70-year-old data for ARVC. For, data for a 70-year-old.
Yeah, it really, it's more about the type of exercise that you're doing and the intensity, and not necessarily the age at which you're doing it. We have some preliminary data that there may be something really unique about intense exercise in the adolescent period that can really drive a lot of presentation, but we're still fleshing that out. I wouldn't go on that, for sure. But we see all the time patients with delayed presentation of disease when they start their exercise later. So I had a woman who had her cardiac arrest in her 50s because she never exercised a day in her life until after she had her kids, and and they were out of the house, and then she found herself in her 40s, and what am I going to do? So she just started long distance running, and then she developed ARVC in her 50s. So it's more about what intensity of your exercise you're doing more than the age.
Okay.
Although certainly the older you are, in general, the slower your arrhythmias are. So your risk of sudden death is less, but not necessarily your risk of progression.
Okay. So thank you. Michaela, I have one. No, Michaela asked, for Brittney, this is for you. She has ARVC, and exercise is often met with a, quote, just don't mentality. And I found that extremely difficult. What do you suggest that isn't walking or something so minimally stimulating?
Yeah, and again, it's going to depend on what your disease looks like, because certainly a lot of our patients, if they're in a phase of their disease where they're really unstable, we're not able to control their arrhythmias, we're working them up for transplant or things like that. Walking may be where we're at right now at this course of your disease. Dr. Calkins talks all the time when we are being more restrictive. He's like, this is not forever. This is during this time. But I would really encourage you to go back to your team. I will often ask in clinic, I will ask patients, because of course it's difficult for Dr. Lampert or I to go through every exercise that is possible ever by anyone at any point. And then patients think new ones. If I could stop talking about pickleball sometime soon, I would be very happy. So I will often ask my patients, I'll say, what exercise would make you happy? If you could do anything, what are the types of things that you would want to do? And then we can kind of backtrack from there and modify what that is, and what types of aspects of those types of exercise are safe given your current disease state. But yeah, I would not take just don't do exercise as an answer. If your medical team's not working with you, then maybe find a medical team that will.
Okay, thank you, Brittney. A question for either one of you. Is it safe to exercise alone, excluding swimming?
So when we're thinking about exercise, so we're now thinking about the arrhythmic potentials, if we're, kind of thinking about whether you're going to be alone or with other people. And this is a place where that shared decision making, that concept of risk tolerance comes in. Certainly plenty of patients with long QT who are well controlled do run on their own. And does that mean the risk is zero? Something could happen to them during a part of the run where they're not around other people. The risk isn't zero, but the risk, as you talk to your doctor, may be so low that it's within the realm of risks that you might choose to take in your life. And that's really where these concepts of shared decision making and risk tolerance kind of come in. And so it really depends on your own situation to think about how much risk that would be.
Okay. Thank you very much, Rachel and Brittney. We appreciate your time tonight, and we thank you for your participation and asking questions. And like I said earlier, this recorded webinar will be available to you in a few days. So thank you for your participation, and good night.
Thank you.